Hi, so welcome to this episode of Sid Talks, and I want to share with you the screen now. So this is a bit about me. My name is Dr. Siddharth Verma, and I'm from Mumbai. I'm practicing exclusive pain medicine, and we will discuss in this talk about the chronic pain after total knee replacement, and what are the factors associated with it, and how can you understand this better. It will be clear by the end of this talk. So why it is important for the pain physicians is because there is a very high incidence of pain after total knee replacement. So the minimum incidence, they say, is 8%, and the maximum in some studies is over 30%. So there is such a high incidence. Not all patients are satisfied after total knee replacement, and pain after total knee replacement is a stronger determinant of satisfaction than function. So if somebody is having good function but still they have pain, so that's a stronger determinant of satisfaction. Actually, if it is such a big problem, just imagine 3 out of 10, that means a big 30%, that means 1 in 3. So every 3 patients who get done with TKR, 1 will have this pain. So this high incidence is there. Then why don't we see these patients? So that's a bigger issue. So often it's just like a tip of the iceberg phenomena. As seen here, often patients do not seek care for chronic pain after TKR. This has been well documented. So they wanted to understand what are the reasons why don't patients seek help for chronic post-surgical pain. And once they started understanding, they found that these patients do not seek help. And overall, the reason was they found an overall sense of futility. That is the belief that nothing further could be done for their ongoing pain. And also their perception of their pain was often discordant with that of the surgeons and the physicians. That means the patient thought they had pain, or maybe they thought they had some issue, but the operating surgeon or the physicians, they thought that they did not have severe pain. So that's the reason after a while these patients stop seeking the help. They get this feeling that nothing more can be done. So how this is a sum total of many different reasons, because of the health professionals response, because of the expectations about the outcome. For example, physio didn't make a lot of difference. They say that nobody has suggested anything else apart from drugs, so they feel that that all the treatment is futile. Also the burden of treatments means, they say that no more treatment, no more operations. I just feel enough is enough. I just feel my time of life, I can't put up with it. Then they feel that the other knee is taking over the top spot. I'm more anxious about my lungs, or maybe some other comorbid conditions, or the moral logic of candidacy. The patient does not want to bother the doctor. Many times the pain characteristics, it's better than it was, but it's not gone completely. So then many times they accept and get on with it. It never changes, so you learn to live. Some patients say like this. So all of this indicates nothing more can be done. And this is a picture taken from one of the papers I have quoted, and quite a recent one. It is definitely a public health problem, because just imagine 7 lakh, over 7 lakh procedures being done annually in the United States alone. And 30% of that means quite a big number. We're looking at say 21,000 patients. So development of a complex intervention for patients. So there was a star care pathway, which they wanted to, and this they will find this mentioned in a number of papers. And they found out that we need the resources and possible solutions for this problem. And some of the solutions they try to identify and try to make some changes in the routine algorithm. And they identified that the patients need to identify it earlier, to ensure that the treatment is initiated at 3 months. So they, instead of they change the screening process. So the second screening process will occur prior to the assessment appointment, to ensure that the patients still have pain. Then the patients who are offered nurse or self monitoring, this was the thing earlier. Physio should be a treatment option, but here physio was a referral pathway. Monitoring was changed to follow up. So this is a regular, the patient has to follow up. If there are any additional red flags like knee stiffness or patellofemoral joint problems, so immediately the surgeon referral was done. Patient with anxiety should be referred. This was earlier to the general practitioner, but signs of anxiety will initiate a GP referral for review and treatment. So this is quite a change. So they found out and they tried to initiate this. And also for neuropathic pain, the reference to the pain specialist had to come very fast. Earlier, it was waiting for the pain clinic appointment. So usually the pain clinic appointment in that particular country takes a lot of time. But here, if there's no improvement in 6 weeks, they will be referred to a pain specialist immediately. Referral to pain services need to be via the general practitioner. Here, they will be asked to request an urgent referral for the complex regional pain syndrome, which requires early and immediate treatment. So how to identify these patients, that's the biggest challenge, and there has been an answer to this question as well. So an Oxford knee score, they found that if the subscale score was 14 or less, so they could get a reference for this. And this was a study of over 1.25 lakhs patients, so that's quite a big population cohort. And this means that one can put a number to this pain and actually measure that what qualifies as the post surgical pain after the total knee replacement. Now, what are the common causes? If the patient comes, the infection can be there, aseptic loosening can be there, instability can be there, malalignment can be. These are normal post surgical causes of the pain after the total knee replacement. But in most of the cases which we will be dealing with, either rare causes like a neuroma can be there, or there can be no cause found also. Can we predict post TKR pain? So this is another question. And some of the studies, they found that depression scores, early grade of osteoarthritis, number of comorbidities, plus individual risk factor. There is one study which says that individual risk factors like smoking, deprivation, obesity, and opioid use are able to predict the TKR pain. Then pain problems elsewhere means in addition to the knee, there are other problems also. It is important to note here that the gender has no effect on this chronic pain after TKR. Pain catastrophization has a very big effect. So that means the patient getting fixed to his or her own pain and modifying the behavior. It has got a lot of effect. Higher preoperative pain scores are associated with higher incidence of this pain. And also there is something known as the conditioned pain modulation, which is very well quoted in one of the studies. I will discuss this again. And this is something which can predict the post TKR pain. So post-operative patient-related risk factors, they are very well documented in various studies. This particular systematic reviews shows that acute post-operative pain, post-operative knee function, they are risk factors. And in addition, psychological risk factors are also there. This is well known, and I feel this is being taken care of by the surgeons and also by the pain physicians as a team. And what are we doing currently for this? Probably a lot of perioperative interventions are being done. And let me tell you about in brief about the evidence for each one of them and how effective they are. So there is a weak evidence for local anesthetic at the site of the surgery, ketamine, pregabalin, early discharge. There's a very weak evidence in favor, but there is evidence. Some evidence is there for electric muscle stimulation, anabolic steroids, and walking training. So this is we are quite low on this. So whatever preventive measures we are taking, although they may help, so they should continue to be taken, most recommendations say, but it's important that their expectation should not be overemphasized, or you should not have a very high expectation. Now here is a myth which I'm going to bust. So effect of pre-surgical intervention, this paper in 2020 BMJ Open. So you can see that it shows that neither pre-operative exercise, education, nor a combination is effective in preventing chronic pain. So mind it, the word here is chronic. I'm not talking about the acute one. So for chronic, it is not effective, they say. And there is also one, why I want to emphasize is those of you who are either from physical therapy or who believe that exercise can counter this, just check out this paper, very recent 2022 paper. And they have mentioned about the effect of preoperative rehabilitation training. And in this whole paper, if you read, they mostly, they talk about the acute pain. And if you search, there's no chronic word only here. So you will be able to understand that in an acute scenario, this may be 3 months or 6 months or whatever, within that time, it can help. But beyond that, it's getting very difficult. Now, the steroid also, many people think that, okay, we'll put in the steroid. It's a negative recommendation, very big no. Many studies have proven it. So don't attempt it. Most of the surgeons already know this. And intra-articular corticosteroid injection after a TKR, it's very unsafe. So please, it is a very high risk of infection. Now let's check what scores to measure. And um, other than the VAS, NRS, they're more used because of their ease of measurement. But if you see McGill pain questionnaire, brief pain inventory, and most importantly, pain detect questionnaire, PDQ, is very important, because this is a good measure for the neuropathic pain component, which can be managed, or at least the patient can be informed in advance about the prognosis. Now, many treatments have been tried, right from oral pain medication to topical therapy to physical therapy, but none has been found to be superior. Some alternative therapies like acupuncture, cryotherapy has been tried. Lifestyle modification has also been tried. And periarticular, intra-articular steroid injections, they are very controversial. Please desist from recommending them. Revising TKR is a more invasive option, which can lead to unpredictable outcomes. So that is also not an option, and this should also be noted. Now, what are the possible solutions? These were the problem parts. So approach this cohort of patients who are going to chronic pain in the same way as any other patient with chronic pain problem, rather than from a purely orthopedic perspective. So that can give better results. If you characterize this pain and approach it in this way, the patient can have much better results. So another paper shows that a conceptual model influences the patient's satisfaction after total knee replacement. And if you can see that after say 3 to 4 years after TKR, the patient can go in either of these two pathways, 1 and 2. So if the patient has a positive transition with no ongoing symptoms or functional limitations, they will have positive thoughts, positive contextual factors, recalibration of symptoms, and hence they will have a higher satisfaction. On the other hand, if the patient is having an ongoing symptoms with functional limitation, they will have negative thoughts and feeling, negative social and contextual factors, and as a result, there will be recalibration of symptoms in a negative way. That is, they will think that other people have no problem, why I have the problem. They may think that I can't do my activities, so what to do about it, and likewise. So this is extremely important to understand. Now, what are the future directions? So many times the implant site needs to be checked. So this is a very unique, you can say, approach, wherein the correlation of typical pain patterns with SPECT CT findings in unhappy patients was done. And they found, they did this, and they found that this can give valuable insights. And you see that in the patients who are having chronic pain, the SPECT lights up. So many times this can give valuable objective results. And also, it's not a new thing. You can just very well just check the degrees of the rotation, and also check the implant placement as well. This is already previously known, but addition of this SPECT will improve greatly the chances of picking up something which is more objective. Now, another direction is a patient-centric analytic approach. In this, so those of you who are interested, just go through this 2021 paper. So it delineates the preoperative risk factors associated with chronic pain profiles. So they say that a patient-centric approach, where you do an analysis of that particular patient, that what is the factors which are responsible for pain in that particular patient, that is going to yield the best results. And that's also a very interesting way to approach these patients. There are objective predictors of post TKR pain also. So just imagine doing a blood test and predicting whether the patient will have postoperative pain after TKR or not. This will be very interesting to the surgeons and the pain physicians. So it's a very recent paper, just in 2020 it was published. So preoperative serum circulating microRNAs as a potential biomarkers for chronic. So it's not a very early stage study. They have done the study and they have documented it. Of course, it needs much more validation, but probably this is going to be one of the future directions. And of course, as a pain physician, this is there are lots of long-term encouraging results for the cool radiofrequency ablation treatment. So you can see people used to ask us for, like, say 3 months whether it will work, or 1 year. Now we have 18 and 24 month results. That is approximately 2 years follow-up is available. And you see that management of uncomplicated total knee arthroplasty, it is they've done this using the cool radiofrequency ablation, and they have found out encouraging results. So this can be one of the very good. This is a 2021 November paper, hardly 3 months old from the time I'm recording this. So maybe this is also going to be a very good possible solution for the cooled RF for the genicular nerves. So these are the references, and just the next step, guys. The secret of getting things done is to act. So those of you who are listening to the talks for the first time, just join our mailing list. Just mail me the WhatsApp group you'll get in the chat, or the email. Just have a chat with me, or just email. And suggestions, comments are welcome. Just direct them to mumbaiPainSchool@gmail.com. And of course, this will greatly augment. Just try to make a habit of attending the journal club regularly. This will greatly help you. And don't forget to subscribe this channel. And I think that will be great. Just hit the subscribe button, like this video, comment, tell us what you think. And also, if you have any suggestion for one of the future talks, just let me know. I will be very happy to consider your request. Thank you. Keep learning.